So today we are going to explore the role of the arts and humanities in medical education and how it supports the development of core competencies. And so we have three esteemed guests. We have Dr. Lisa Howley. She is the Senior Director for the Transformation of Medical Education at the Association of American Medical Colleges. We have Susan Imus. She's the professor and former chair of the Department of Creative Arts Therapies in the School of Fine and Performing Arts at Columbia College, Chicago, and UAB's Dr. Stephen Russell. He is an author and associate professor of internal medicine and pediatrics at University of Alabama at Birmingham. So now I will turn over the spotlight to Dr. Howley.
Thank you so much, Kimberly. It is my honor and pleasure to be here with all of you today. Thank you for this opportunity. I'm pulling up my slides now. There we go. Can I get a thumbs up? Thank you, Kimberly. Really excited to hear that the focus, of course, of today's session is on arts and medical education. I am a educational psychologist. I work at the, as has already been mentioned, at the Association of American Medical Colleges. I do not have financial disclosures. I do work full-time at this nonprofit association, member organization. And some of the work that I'm going to be talking about today is funded in part by a number of organizations. So I just want to acknowledge them: the National Endowment for the Arts, the Josiah Macy Jr. Foundation, the National Endowment for the Humanities, and the Corporation for Public Broadcasting. A little bit about our organization for those who may not be familiar with the AAMC, as we refer to it as. We are a member organization of medical schools, teaching hospitals, and specialty societies. So our members currently make up 158 MD granting medical schools, including the University of Alabama, and as well as about 400 teaching hospitals and about 80 specialty societies. So really, we have a pretty broad and deep membership base in regards to academic medicine. You can see there our mission statement is to lead and serve our academic medicine community to improve the health of people everywhere. And it is really my honor to be able to talk to you about today specifically about the role of arts and humanities in helping us meet and achieve that mission. And as I begin, I'd like to open with a little bit of humanities in this case, and the arts. This is a 55-word story, which was written by Mickey Calderon. She's currently a fourth-year medical student at Tufts School of Medicine in Boston. And she wrote this during the pandemic in February of 2021. And if you don't mind, I'd like just to briefly read the poem, and I'll give you a little bit more background information after I do. She titled this, "The Things I've Learned." I've learned to smile with my eyes so they can see that I have a soul. I've learned that a moment of silence, a reflection of the things that we hold dear, will allow us to proceed with purpose. I've learned we're more alike than we'd like to think. We all want to be loved. So if you're not familiar with 55-word stories, they are a unique humanities activity or artistic endeavor to help share a brief story in a rather succinct way, in a succinct style. It's become rather popular in medicine, medical education in particular, and I just loved this one. I wanted to share that with you all, and thank Mickey Calderon for that gift. So during the pandemic, the AAMC, my association, and in partnership with a number of other organizations, including StoryCorps, the Good Listening Project, the National Endowment for the Arts, we put out a call for 55-word stories and poetry. And as a result of that call, over the course of about 18 months, we created a lovely collection from all across the country, over 200 submissions, and we currently have that archived on our website, and I'll give you information about that and how to find that in just a moment. So I just wanted to mention that it is a very nice collection that we refer to quite often, actually. On the right side of the screen, you see a number of masks, and this was actually an activity that the same medical student did with a faculty member, and Mark Stevens at the time. And it is a unique craft technique or approach to help with professional identity formation. And the masks here are both painted or crafted on the outside and the inside to reflect kind of the outside persona as well as the internal processing and emotions and feelings that may have been going on by that healthcare professional at the time. In this case, these were all created by medical students. And so just wanted to share just a couple different ways that the humanities and the arts are being incorporated into medical education. And in 2018, the National Academy of Science, Engineering, and Medicine put out a lovely report called Branches from the Same Tree about the role of arts and humanities in higher education, including medicine. But it was much more broadly focused on higher education in general. And they defined the arts as teaching a creative means of expression, understanding different perspectives, awareness of knowledge and emotion through the human experience, and the shaping and sharing of perceptions through artistic creations and practices in the expressive world. The humanities teach close reading practices that is as an essential tool, an appreciation for context across time, space, qualitative analysis of social structures and relationships, the importance of perspective taking, and the capacity for empathic understanding and analyses and structures of arguments. There are many examples, and I want to introduce you today in just a few moments that I have with you to an initiative called FRAME, which stands for the Fundamental Role of the Arts and Humanities in Medical Education. This initiative, we began this in 2017, almost 8 years ago, actually, when I first came to the association. This is one of my first efforts really when I came on board, and was to help formalize and think about the role of the arts and humanities in med ed. Until that time, we had really not done that, nor had any other national organization in our field. And so it was really an honor at that time to bring together a number of thought leaders in 2017 and help us shape and frame what we refer to as FRAME. Our primary goal of this national initiative is to improve the practice, education, and well-being of physicians through a deeper integration with humanities in the arts in their professional development. And I know we're going to hear in just a few moments from two amazing medical educators about their work, and so I won't belabor that too much. I do want to give you a little bit more background about our work and what led to our national initiative that we have here. We conducted early on a scoping review. Few of the publications that resulted from that commission review are provided here for you. It was an amazing team led by Tracy Moniz, and they found a number of things. One, that most of the literature in this space was focused on medical students and using the arts and humanities at the medical student level. So we have called for an increase across the continuum of education and across professions. Most of these most of the work at that time was within our siloed house of medicine, if you will, so the work was not being done or looked at as an interprofessional endeavor. So we've put out a call for increasing interprofessional collaborations and work in this space. And also that the work was being led mostly by medical educators, with a lack of, or insufficient, I would say, involvement with the arts community and the humanities scholars. So again, put out a call and a recommendation that we work across our professions and collaboratively to realize even greater outcomes related to arts and humanities in educational practices. We funded a number of grants for some of our members, 8 of our members. You can see them listed here on the left side. And I've gone ahead and just included the titles of their projects because they were all quite different, quite diverse, and quite interesting, actually. All of these integrate different approaches using different art forms and humanities approaches into their curricula. They are all working with different types of learners, if you will, from faculty and community partners to medical students and resident learners, of course, and really the diverse number of topics and ranges. So arts and humanities really being used to address a number of different competencies, everything from, as you can see, addressing equity, anti-racism, and belonging to end-of-life care. We have lots more information about all of these programs if you're interested, available on our website too, and I'm happy to share that with you. Speaking of our website, one of the things I wanted to mention today was a report that we published in December of 2020. So this was during the height of the pandemic. We were able to release this monograph, which is still very relevant and frequently used today. It includes really a background, historical context, results and findings from the scoping review that I've already mentioned, a number of examples of how arts and humanities are being integrated into medical education programs, and also a number of recommendations, which I'll briefly share here. There are 7 of them. I've already kind of spoken to some of these. I'm not going to go through and read them all, but I do hope you'll, if you're interested, would take a look at that report. It is freely available on our website for you to access and use, and I'll put the link in the chat as soon as I'm finished sharing my slides here. Our work really is to continue to help support our members in meeting those recommendations, those 7 recommendations that I just shared. One of the ways we're doing that is by created what we call the Getting Started Guide. So those of you who are new to arts and humanities and health professions education, really actually broadly, invite you to check this out. This is called a Getting Started Guide. There are 2 parts to it. The first part breaks out various different art forms and humanities approaches by competency domain. You can see those listed there at the bottom. Those are the 6 core competencies in medicine, medical education. And then the second part is more repositories and approaches and lists for helping in other ways. So this isn't specific to curricular integration, but this is a little bit more broadly, and it's focused on various art forms and media. Finally, as I end and wrap up and hand this off, I want just to invite you to stay in touch with us, with Frame. We do have a newsletter, and that comes out about 6 times a year, and would love for you to be a recipient of that and stay in touch with us. We have a number of virtual events throughout the year. We're actually starting a new virtual learning community this spring, and so you'll be hearing more about that, and I hope another way to connect much more frequently with colleagues, with other educators who are interested in working in this space. So we see this virtual community as an exciting way to do that. And with that, I will stop sharing my screen, and thank you again. I look forward to the Q&A, which I think we're going to hold till the very end, but thank you so much.
Thank you so much, Lisa. That was great information. And now we will turn it over to Susan.
Thank you. I want to begin by saying how honored I am to be here and to thank Kimberly for inviting me to speak about my work with you today, which is on dance movement in medical education. So if we could start the slides, Dana, that would be wonderful. Okay, next. A little bit about myself. I am by training a dancer, also an actor and an artist. So I guess I would say I'm an interdisciplinary artist. I'm also a licensed clinical professional counselor I'm a nationally board certified dance movement therapist, and I'm a certified movement analyst in Laban-Bartenieff studies. I'm a full professor at Columbia College Chicago, where I currently co-coordinate the Arts and Health minor that I founded in 2013 and is still very active. And then I used to chair the Department of Creative Arts Therapies from 1998 to 2017, which was sunsetted, unfortunately, at the college. Next. So today I'm going to introduce a little bit about the dance movement therapy medical education model that my faculty and I created in 2006 called Embodiment, A Way to Know Your Patient. I'm going to explain a little bit about the theoretical influences from dance movement therapy. And then we're going to end by looking at a little video that will help pull some of these theories together and help you understand a little bit more about the assignments that I utilize from a dance movement perspective in the medical education humanities courses with which I teach. In 2006, to give you a little bit about the history, the Society for Arts and Healthcare, which preceded NOAA, the National Organization for Arts and Health, they had their annual conference at Northwestern University. And at that time, I was introduced through Catherine Bellamy to her medical ethics and humanities course. And she invited my faculty and myself to create a course, or a module, I should say, within their medical ethics and humanities course. And we created a 5 2-hour class module with all of my faculty. So 5 of us each took one session. And as I mentioned previously, we titled it at the time, Embodiment, A Way to Know Your Patient. Next. And then later I was introduced to Dr. Jay Beal, who runs the Medical Humanities elective at Rush Medical College at Rush University. And my faculty and I continued our course and embellished it to extend it to 5 3-hour classes. And once again, it was called Embodiment, A Way to Know Your Patient. And then more recently, I have renamed our course Embodiment, A Way to Know Your Patient, Take 2, because we are still doing 5 3-hour classes, but it is myself running 4 or 12 hours of the curriculum and my colleague Jessica Young coming in for 1 3-hour class. What this has done is it's allowed the course to become more cohesive, more consistent, and allows us to do a lot more improvisation, being in the moment and creating with what surfaces with the medical students' ideas and interests and creative process. Next. So, what is the course description for Embodiment, A Way to Know Your Patient? You can follow along with me. It's as followed. To be embodied is to know in and from the body from a subjective place. Healthcare practices can paradoxically become disembodied, objectifying the patient, the provider, and their bodies. Tools mastered by dance movement therapists, such as kinesthetic empathy, movement observation, and nonverbal attunement, offer methods of fostering more accurate observation, assessment, and stronger therapeutic relationships. Dance for self-expression, collaboration, creativity enhancement, and fun is facilitated to emphasize self-care and community care for the caregiver. Next. So these are our course objectives. One is students will experience dance and movement play with self and others. Students will explore assumptions about their own body, mind, and that of their patients. Students will identify their own movement preferences according to BESS, and BESS is an acronym for body, effort, space, and shape. Students will learn to attune and identify misattunement or clashing to enhance empathy in their therapeutic relationships. Students will differentiate their objective versus subjective movement observation skills, and students will examine their self and community care through dance and movement. Next. I've differentiated a little bit on the words dance and movement so you get an idea of the breadth and the depth of the work. And that is dance is utilized once again to increase expression, release kinetic energy, foster creativity, understand collaboration, and have fun. And that's the dance artist in me. We actually get the medical students in the first, I would say, 10 minutes, they choreograph their own dance and perform it. And they are so surprised, and that in itself starts the hook that keeps them interested and curious about what is to come next in our courses. Movement then is used to understand intra and interpersonal patterns of nonverbal communication and their impact on clinical observation and assessment skills and the development and maintenance of therapeutic relationships. And this is where my dance movement therapy training comes into play, and in particular the use of the movement observation and analysis skills. Next. Dana, next. Oh, thank you. So these are some of the theoretical influences from dance movement therapy within the module. We use what I previously mentioned was the BESS acronym, and that's from a system of movement analysis called Laban-Bartenieff movement analysis. And the body is what parts of the body are moving, what kind of sequencing or simultaneous movement in different parts, what body parts might initiate the movement. And then we look at effort. And effort is how the movement quality is created. In other words, what is your timing? Is it fast, slow, more of an in-between? What is your use of weight or strength? Do you use increasing pressure or decreasing pressure? What is your orientation to space? Do you tend to be focused or multi-focused in your use of space? And how about flow? Flow is the stopping or the ongoingness of movement. Do you bind your flow or do you free your flow? Space is where the movement goes, and we find that there's patterns. Do you ever notice your students like to sit in the same space in the classroom? And then shape. Shape is about, why am I moving? You know, am I shaping my body forward, advancing in the space, retreating, expanding or widening, narrowing? All of this is a postural shift. It's not necessarily where you're going, although it does delineate that, but it's why. Am I moving towards something because I'm interested, like your patient, or am I moving away because the patient is offensive or they maybe don't smell very well? That's what the shape quality is. And then we also use the Kestenberg movement profile to help our students understand what we call shape flow adjustment. That's a little bit of what I was showing. And that relates to breath support. When you breathe in, how does your body change in its shape? As you exhale, how does your body change in its shape? And how does that relate to your anxiety or the tension you might have with certain people with whom you interact? And then the next is tension flow attunement. And once again, that's the binding and releasing and that kind of tension you hold in your body and how that can be problematic for others. If you present as a tense person as compared to somebody that's a little bit more free-flowing. Next. So the last theoretical influence that I want to present to you is called authentic movement. And this is a practice that was created by dance movement therapists, but it's utilized a lot in the dance and theater worlds. And there is a role of the mover and the witness, which interestingly enough mirrors the roles of patient and provider. And each role assists in identifying and differentiating subjective experience of sensations, movement, images, feelings, and thoughts. And that acronym is SMIFT, from the objective observation. That leads to the differentiating between the story, images, feelings, and thoughts, from concrete symptoms of sensations and movements with illness. And this is something that I utilized a lot when I was a clinical manager of a chronic pain program at Pilgrim Harbor Community Health Plan. Okay, next. I'm going to get to our assignments and give you a little sample. Each of the students have to keep a journal, and we give them a little bit of time at the end of every class to reflect on the experiences that they've just embodied. And then at the end of the course, they have to do a reflection response paper. And then throughout this, they are designing and creating their image of health. That is an artistic creation, and it is accompanied by an artistic statement. So let's look at that very quickly. Daniel, can we show the video?
And Susan, we will have time for the 4-minute version.
Okay, thank you.
The box. We all have it. The wooden box in the back of our mind, covered in nails and shards of glass, stored in a room with a double bolt lock on a steel door. Day after day, we visit this room, bearing fruits and vegetables, supplements, hand sanitizer, storing yoga mats and treadmills. On top of the box they go, a tower of health. For some, cigarettes, violent neighborhoods, and food desserts crowd the room. The box does not like this. Black tar oozes from the cracks. The box will open one day for all of us. For some, it opens more than once in a lifetime. I've seen what happens when a box opens. A crane comes and moves the box to a new room, one in front of the window with a view. The tower toppling down during transport. Pills, therapy, and doctors fill this new room. The body starts slowing, gears stuck. The music of air that once echoed in the hallways, muddled by the sound of construction. The spotless floors, riddled with pests. Some close this box, make repairs, but some never do. Hello, and welcome to Series 6 of Images of Health in Rhythm with Our World. My name is Susan D. Imus, developer of the Images of Health series, coordinator of Arts and Health, and associate professor in the Dance Center at Columbia College, Chicago. Previous series, which provides the scope of the project, includes the following community partners: Hines and Jesse Brown Veterans Medical Centers, Rush University Medical Center's Department of Social Work and Community Health, Connections, Dance Movement Therapy Program for Brain Injury, the Museum of Contemporary Photography in Chicago, and Rush University Medical College. Today's show includes images from returning partners from the Museum of Contemporary Photography, Connections, and Rush University's Medical College. The Medical College offers a medical humanities course elective for first-year medical students led by Dr. J. Beal. I teach one of the modules and require all the students to create their personal image of health. You heard Nicole Rossi's image titled The Box at the onset of this video. Collages, photographs, and drawings were all presented during the medical students' last class on March 13th, 2020, the day before our college and the rest of the world shut down. Our arts and health students collaborate each spring with the medical humanities course at Rush. This spring, another collaboration took place with my advanced topics in dance course that explored arts and health with the music department's Studio Composition 4 course taught by Ilya Levinson. In total, 25 students explored health through the creation of auditory, visual, and kinesthetic images. 8 medical students, 6 music composition students, 10 dance students, and 1 film student. My students explored health through artistic inquiry. They interviewed 8 people each from diverse populations to expand their understanding. 75 people in total were interviewed. Students synthesized their narrative interviews through embodied writing, choreography, and filmmaking. Interviewees contributed to some of the gestures represented in the choreography you will see in this performance. The image making changed dramatically with the COVID-19 pandemic. Students described changes in their art making as suffocating, trapped, and surrendering.
So the Image of Health project is one that I'm continuing. I taught at LaSalle College of the Arts in Singapore and collected images there. And I also last year taught at Aalborg University and have images from the students in Denmark. So I'll keep you abreast of that information and that project when I get my research completed. And lastly, I just would like to, next slide, say thank you. It's been an honor to speak with all of you. If you have any questions for me, feel free to contact me directly. And here is the notification of the photographer who is taking the photos that you see in the slides. Thank you again.
Thank you so much, Susan. And now our third guest, Dr. Stephen Russell.
Hello, my name is Stephen Russell. I work here at UAB in Birmingham, and I want to take just a couple of minutes to share with you one of the projects that we've done here. I had the opportunity not only to see patients, but to work with medical students and residents, those who are in their postgraduate training. And a very common question that we ask outside of a patient's room after we've been in there is, what did you see? And it's an important question, both for a diagnostic purpose, both for a therapeutic purpose, and to understand what the student is actually gaining from that experience. But what it gets to at the heart of it is something known as visual literacy. And I think many of us, I certainly did in the past from my own training, take visual literacy for granted. In just a moment, I think my slides will be pulled up here, and thank you. And so I wanted you to take just a moment to look here and say, what do you see? You look at this picture. This is a picture from about 125 years ago, at the end of the 19th century, when a person, an artist, was asked to paint an image of social significance. And this painting, done by Sir Luke Fields, is simply known as The Doctor. And many people will see the very beginning the very center of the image, the young child who's sick, the doctor who's spending some time considering what's going on. But many people may miss the upper right-hand corner of the light that's coming through what appears to be a window or a hallway, or presumably the mother whose arms and hands are wringing together in anguish, or perhaps the father who's more in the middle center of the upper right-hand corner with the comforting hand on his spouse's shoulder. So there's a lot to be seen, and much that we see that is at first glance, and other things that we can see at more subsequent glance, and that's known as visual literacy. On the next slide, what we'll see is an example of consideration of visual literacy in medicine. This is 4 images of a well-known physician in antiquity named Sir William Osler, where he describes 3 separate ways in which we consider a patient. The top left-hand corner is observation, followed by percussion or palpation, feeling what's there. The bottom left-hand corner is auscultation. But then the final one, which perhaps we don't give as much time for, is contemplation. And you can see both what Luke Fields represented and the picture of Sir William Osler is a physician who's taking time to consider, to observe. And we would like to think if we were on the receiving end of that, that we would feel the physician's attentiveness and connection as well. Next slide shows one of our very first sessions at UAB for the prescribing art course at the Birmingham Museum of Art. And about 25 years ago, in 1999, a study was published that sought to see if we could improve medical students' observational skills by putting them in a new environment, something that's outside of the typical clinics or typical hospital realm setting. This was done from the Yale College of Medicine in association with the art museum there, the Yale Museum for British Art, I believe. And what they found is that when students are removed from a familiar setting, they're much more likely to be attentive to things that are directly in front of them. And they used a scale and a pre and post test to be able to demonstrate that, in fact, the students who went through this class compared to their classmates who didn't had a higher attentiveness both in things that were unfamiliar, such as in the art museum, but also in things that should be more familiar, such as in the clinics and in the hospital-based setting. And so in 2011, we started with the Birmingham Museum of Art. And over the last 13 years, we have moved, in addition to the Birmingham Museum of Art, to our local AVA Institute, the Abrams Ingalls Institute for Visual Arts at UAB. We've also added in our medical library, medical collections at the Lister Hill Library. And more recently, we've also incorporated the Birmingham Civil Rights Institute. Each has various museums where students can go and be present and see things that may be outside of the medical context and use that unfamiliarity to teach about observation and to teach, hopefully, something about medical education as well. On the next slide, you'll see some of the more obvious parallels that we start to get into. We think about, from the left-hand part of the screen, in dermatology, we consider the A, B, C, D, and E aspects of a rash, the asymmetry or the border, the color, perhaps the diameter, or is the rash evolving? And that actually can line up quite well with formal analysis in art, looking at asymmetry or symmetry, looking at border and outline and line, thinking about color, size, and shape, and pattern. And one of the things we do after we introduce the similarities in language is we start to go to areas of art on the next slide that may be unfamiliar to them, but do have medical representations. In the top left-hand corner, we ask the students to look at this and, acknowledging that the nose was cracked and that's not the abnormality, can they find the medical abnormality in this sculpture that was done around the 1st century BCE? And for those of you who are medical or who are wondering about it on the call, on the Zoom, it's actually the earlobe, and that has the earlobe crease. Actually, it's not just the slip of the chisel, but that's actually a known medical abnormality that wasn't described until 1974. In the center of the slide, we look at an altarpiece and ask the students as well, can they find any medical abnormalities? This is an altarpiece from the 15th century, and in fact, the students can see some things at this gentleman's temporal lobe region, also perhaps about his hair pattern, or maybe some of the skin findings of the cheek. And then in the bottom right-hand corner, we ask a similar question for something in the 15th and early 16th century, and recognizing that on the end of the nose, there's a medical abnormality as well. And the important part that we want the students to know is not so much that can they identify the medical abnormalities, but the 3 separate artists who represented these from 2,000 years ago and 400 and 500 years ago, these 3 artists had no medical training that we know of. And in fact, the description of these medical abnormalities didn't exist until about 150 to 100 years ago. And so the part that we want to emphasize to them is you don't have to be experienced in medicine to be able to see abnormalities. You just have to be aware of the patient who's in front of you. On the next slide, this is one of the foundational pieces that we use at the Birmingham Museum of Art. Erasistratus, the physician, discovers the love of Antiochus for Stratonici, painted in 1792 by Benjamin West. It's a beautiful painting on display in the Birmingham Museum of Art. And we spend some time asking the students to tell us what they see, purely by description, not from a diagnosis standpoint. And over the course of about 20 or 25 minutes, sitting in front of this painting in the Birmingham Museum of Art, we start to create a story, a narrative that in fact lines up with the information that we have from the historical narrative of this particular painting. And at the end of the class, the students are asked to provide their own reflections about what they thought about the paintings and the activities that they did. And on the next slide, you can see a comment from one of our students who said that there are things that present themselves after intentional looking that are not apparent at first glance. And that's really what we hope for our students, is that through time and intentionality, through being physically, mentally, and fully present in front of what's in front of them, they're much more able to see things that might not present themselves with quick looking or fast looking. As the week progresses, on the next slide, we start to look at things that may have less of a narrative focus. This is another piece that is at the Birmingham Museum of Art known as Barbie, painted in 1964, where Grace Harrigan uses a contemporary form to be able to express what she subsequently named as Barbie. And for those of you who are looking for a narrative focus in this, it can be hard to see. It certainly was for me the first several times that we used this image. But when we spend time thinking about it, when we have a free flow of conversation among the students, one of the things that we see on the next slide is students reflect and say that one of the things they learn is that it may take several perspectives and several different angles to put together a complete interpretation of the patient. And on the subsequent slide, we see another student who looked and, after reflecting on this particular image, said, "The painting helped me realize that I see patients and can get so overwhelmed with the diagnosis that I miss what really means to see a patient." On the final slide, we know that there's so much that goes into training any profession. There's the knowledge base, and until the knowledge base is gained, it's really hard to pay attention to some of the stuff that may not be as readily available for students when they first start medicine. But if we think back at the beginning slide, one of the things we recognize is there's a commonality among both patients and providers of what's expected and what it means to care for a patient. And of course, we are all better off because those images of those who are sitting in the physician's seat are different in 21st century medicine than they were in 19th century medicine when this painting was pictured or was created. But one of the things that hasn't changed is that being skilled at a craft both helps those who are receiving the craft, in my profession, the patients, but also the craft person who is training in that profession. And of course, in my position, physicians as well. So what we hope is that the students will take in the week-long experience that they have an opportunity to slow down, to look, to listen to their colleagues, and to come up with something that may be surprising, but hopefully something that will benefit them as providers, as well as benefit their patients to come. So thank you for listening. Thank you for being a part of this. Now I'm going to mute as we take some questions from the audience.
Yes, oh, thank you so much. And something that I just keep thinking about as I hear each of you speak is just the importance of these things for human beings in general, you know, to engage with other people and to stop, slow down, be intentional, really look and see people. And so yes, and it's important for our future physicians as well. I don't think we have any questions yet, but I do have a question. And my first question is for Susan. And I'm wondering, you mentioned the concept of attunement and misattunement. Could you just share a little bit about what that looks like, what that means in a medical setting?
Sure. Attuning means the easiest way to describe it would be matching or entrainment Attunement follows the laws of entrainment that happen all throughout nature. And you might even think of like a plant, how they want to attune towards the sun to get the light and the nurturance. With us as human beings, we attune automatically when we are in sync with someone. There's research out there that says, you know, your heartbeats attune, your breathing attunes, and that's something we can teach the students how to connect or attune with their patient by following the breath, by noticing how the patient is breathing and then changing their breath to meet them where they're at. And if the patient is anxious and is breathing quite quickly, they might start there and then slow the inhalation and exhalation down so that the patient then will entrain or attune with the doctor. So that's one example, and that would be rhythmic attunement. But there are many, many kinds of attunement. There's touch attunement, there's rhythmic attunement, there's effort attunement, there's the tension flow attunement. And it's a whole system that was created by Dr. Judith Kestenberg. And I have resources that are available on my PowerPoint for folks. If you're interested in learning more, they're not direct references because I didn't reference any of the materials, but if you want to understand some of the background in dance movement therapy theory and some of the literature out there, I have some basic resources listed.
Thank you so much, Susan. And of course, we have a questions just come in, but for all the panelists, or maybe start with Dr. Russell, in today's fast-paced medical culture, where appointments are often 10 minutes or less for the clinical encounter, how do you reconcile or teach students to slow their perspective to be intentional while balancing the demands associated with modern patient care?
That's a great question. Thanks, Renee, for that question. It's a challenge. So let me first acknowledge that, and it's done imperfectly by folks that are trying to do it. But for me, in speaking to the students, I think the fundamental aspect is curiosity. Curiosity, teaching the students curiosity. So the idea of, are they curious about the patient in front of them, what's going on, what's the experience of what's going on, and then are they also curious about the condition that the patient has? It oftentimes will bleed over into the 10 minutes that one has. And so I think from that standpoint, it's a matter of prioritizing what needs to be done in the presence of the patient as opposed to what can be done outside of it. But I think if my students can take away a sense of curiosity with each encounter with their patients, I do think that it helps to slow down and make folks be able to connect better, but also to listen better.
Well, we do have a question about, is any of this work taught in UAB's nursing school or counseling program? I cannot speak for the nursing school. Perhaps we have someone from that department from the school here who can chime in. The counseling program, I did graduate from that, and I don't recall any specific arts integration into that, but there is narrative therapy, of course, that is touched on, and some creative approaches. But I did want to ask Dr. Lisa Howley a question, and is there anything surprising that you encountered in kind of on this journey of creating and writing and researching the frame? Is there anything that you weren't anticipating that kind of came out of that work?
Thank you, Kimberly. If you don't mind, can I go back just very briefly, since I'm now off mic or off mute, about the comment about time, and I just to add on to Dr. Russell's comment, which completely agree, and in the comment itself, with how precious time is, especially in those patient encounters. we also have data, and we know through research that patients can feel either connected or disconnected with their healthcare professionals within a matter of seconds, right? So it's regardless of how much time you end up having, it can you can form bonds and connections within a very short amount of time, right? And so these experiences and thinking about slowing down, it doesn't necessarily mean dragging out time and doing less in amount of time. It has to do with body regulation, body language, for example, direct eye contact. I mean, there's a lot that can be done and a lot that can be learned through these exercises and curricula that translate into fostering those connections, regardless of whether you have minutes or quite a bit more time, right, with your patients. So I wanted to throw that in. And then your question about surprising. Probably I would say that I mean, I always knew. So I have a personal. Prior to joining and taking on the role at the association, I did my own work in creating curricula and partnering with a local museum and to build programming around that for healthcare professionals. So I came into the association with that background and that my kind of own personal interest in this work, but have learned so much more through all of our constituents. And I would say that the pandemic has, I don't know if it's a surprise, but it very much reinforced the need for this work. We saw many sparks of interest during and since the pandemic, actually. It really, I think, called us to think about what it means to be a human in this field, in this space. When we unfortunately had to be physically disconnected in many ways from patients, it really called into question the healthcare professionals' own identity and what that meant, and how they could reconnect. And in many ways, the arts and humanities allowed us and them to do that much more effectively and efficiently than any other kind of pedagogy, if you will. So I would say I don't think it's a surprise that the pandemic did that, but it definitely, we've definitely seen that impact.
Thank you, Lisa. And we just have a few minutes left, and so I just wanted to kind of hear from each of you, just like any last closing comments or thoughts that you would like to share. And I will start with Susan.
Yeah, thank you. I guess I would like to say that understanding subjective experience is a really important part of what we help the students learn. So their interpersonal understanding of how they perceive the world through how they think, how they move, how they image, how they feel, and what sensations occur. And that helps them differentiate from the patient so that they're not, transferring some of their own preferences onto what and whom they are observing. So self-awareness is crucial to the work that I do in dance movement for medical education. That's it.
Stephen, Dr. Russell, would you share?
Yeah, I echo that from the work that we're doing as well. Just the idea that meeting patients where they are and being open to their both similarities with things that patients may have, but in particular the differences that patients and providers may have, and recognizing that there's a real opportunity to learn from each other. And as I mentioned earlier, the curiosity helps with that. But I really think that being intentional, as you described, is super helpful.
And I can't say it any better than my co-presenters actually have just said. I will just do another final plug for staying connected with or learning more about our Frame initiative, really are working to build that community, and hope that those of you who've joined us today would consider doing so we can continue to learn with and from each other, and improve all that we do in academic medicine. So thank you.
Wonderful. Well, thank you all for your just incredible wisdom and sharing your experiences with us. And thank you everyone for joining us. Karen, yes, the recording will be available. But I just wanted to thank everyone for joining us today. Our next Virtual Mental Health Monday will be April 15th, and we'll be talking about the role of the arts in military settings. So thank you all so much. Again, so appreciate your time and expertise. Goodbye.
Thank you, everyone.